Good morning, everyone. This is Kathy Bush, and welcome to the DandleLION Medical Webinar, Baby, It's Cold Out There. We're so pleased to have Liz Drake join us again as our faculty presenter. Liz has been a practicing neonatal nurse for 34 years. She received her master's degree, neonatal nurse practitioner, and CNS certification from UCLA. She has practiced in different roles throughout her career, but the time spent at the bedside with the patient, family, and team members is most meaningful. Quality improvement, neuroprotective care, and family partner care are her passions. She has a strong desire to teach all members of the healthcare team about the uniqueness and language of the premature infant. As an active clinician, Liz focuses on how every touch and relational experience we have with a premature infant and their family can have impact. She's also a driver for quality improvement initiatives as she is actively involved with the RN-NIC Collaborative. She's an advanced practice nurse and currently the CNS and the NICU at Chalk Children's of Orange County, Mission Viejo campus. Liz is a published author, a nationally recognized speaker, a national conference presenter, and consultant. Liz, turn it over to you.
Thank you, Kathy. Can everybody hear me? I'm assuming yes, unless I hear otherwise.
Yep,
okay.
We can hear you.
Awesome. Okay. Thank you all for being here. Being it's the holiday season, I was going to start my presentation with singing Baby It's Cold Out There, but I'll spare you all. I did wake up this morning not wanting to get out of bed because it was cold and windy here in Southern California at a whopping 57 degrees. I know, don't laugh. But I am an East Coast transplant, so I do know cold. My blood is thin, so here I am in the warmer weather. But I will tell you that thermoregulation is one of my favorite topics. I think it's probably foundational to really everything we do, and I think sometimes it goes unrespected or unnoticed. And so I want to bring a little bit of attention to it and apply it a little bit more into what we do now, because a lot of our thermoregulation education happened before and charts and things like that happened before we had double-walled isolettes and the amazing equipment that we have now and before developmental products and things like that. So we're going to try to make this as practical as possible. So here we go. So our objectives, hopefully we will cover all of these, and we'll talk a little bit about the difference between thermoregulation of the adult versus the preterm and the full-term infant. We'll talk about 4 methods of heat transfer, which we all know. That will be a review. I do want to focus a lot of attention on the importance of axillary and skin temperature monitoring. We'll talk a little bit about hypothermia and hyperthermia, and then let's talk a little bit about some practices that we can modify because of equipment and environmental modifications that we might need to make because of infant types and different equipment we have. So I think we have to really realize that studies have shown that hypothermia is an independent risk factor for neonatal mortality and morbidity. Just like we have Vaughn talking about our high-risk morbidities, NEC, IVH, the literature shows hypothermia is separate. It's not linked to anything other than its own risk factor. And really no other factor is as important in newborn survival as its temperature control. And I think we need this thorough understanding of thermoregulation to provide this optimal environment for a neonate to thrive. We'll review a couple of definitions of terms. We've all heard NTE, neutral thermal environment. That's that narrow range of environmental temperature where without it, the baby doesn't need this increase or decrease in heat production above resting level. So it's that baseline requirement. And it's where minimal oxygen consumption occurs. And if we look at what it is like inside mom, her in utero temp is 37.9, or that baby is resting in 100.2. And so if you think of deliveries, when that baby comes out into the cold delivery rooms that we have, it's not surprising that it's kind of a shock to their system. The term thermoneutrality is that state of normal body temperature and oxygen consumption that, again, causes minimal heat production. And it's that optimal condition that supports the internal functions, those important body organs. Thermo balance, or I like to call it like each of us has this set point, and that's the rate of heat generation and heat dissipation for us to be comfortable. And we all have a different set point. You know, it's thought that men, you know, they like it colder and women like it warmer, but each one of us has a different point. I can have a temperature, if my temperature is 99, I have a fever where somebody can be 100, and that's when they feel the effects of having a temperature. And that critical temperature is when O2 consumption is increased in an attempt to maintain body temperature. And we know with these babies, if they're already having RDS or oxygen needs, if we get to that critical temperature and they're already in 100% oxygen and desatting, they're really going to be in trouble. So those are just some definitions. So let's look a little bit at the risk factors that contribute to vulnerability of thermal stress. Well, one of the first things is that babies have limited stores of metabolic substrates. And their heat production is very different than ours. We warm by a definitely different mechanism, and they do it by something called non-shivering thermogenesis or burning of brown fat. And we'll talk a little bit more about that in a few minutes. But they have a greater surface-to-weight ratio, and because of their skin integrity, you know, sometimes it just looks gelatinous on those very tiny 23, 24, 25 weekers. So they have even an increased high evaporative loss due to that. Many of them have an immature CNS, so there's going to be delays in response to cold stress, and then we can look at our infants who need cooling. And then the other thing is heat production obligates oxygen consumption, and that really presents challenges to the immature cardiopulmonary system. So what are some factors contributing to vulnerability to thermal stress? There's three. There's insulation factors, vasomotor factors, and behavioral factors. And insulation factors are things like limited subcutaneous fat, muscle, and tissues. We know that they don't really have that musculature yet. That smaller body diameter. If we look at vasomotor responses, those are the ability to regulate skin blood flow. And actually, that is competent in babies as little as greater than 1 kilo. The problem is that vasoconstriction abilities are outmatched by vasodilation. So if a baby can vasodilate easier, you're going to have more of those evaporative losses and things like that, and that heat loss. And then behavioral, those are things that are limited. You know, these babies have limited ability to communicate. So I put this picture here. When we're cold, you put a fire on, you put sweaters on, you have a blanket, and you can warm up. But these poor babies, in a warmer, they can't hold up the sign that says help. They have no volitional ability. Their cues are very subtle and nonspecific. So that's why we really need to understand thermoregulation, because this is something we truly have to do for them, because they have no volitional action to bring themselves to a warmer state. So what are some other factors placing an infant at risk for cold stress? We talked about their vulnerabilities and things like that, but this is a list of types of babies that are going to be more susceptible and more at risk. So our SGA baby or IUGR baby, they have decreased subcutaneous fat stores and adipose tissue, that white fat that we have to keep warm. I wish we had less of it, but thank God we have it. And then infants with HIE, you know, you need an intact CNS needed for heat production. Our infants with metabolic disorders or endocrine disorders, they have impaired brown fat metabolism due to inadequate catecholamine and hormone production. They also have decreased glucose available for heat production. What about our cardiovascular babies? These babies have decreased oxygen availability and an increased risk for metabolic acidosis. And they have the inability to increase their metabolic rate and reduce that metabolic needs. Our infants with RDS, we have infants that are tachypnic, which causes heat loss. They have decreased oxygen availability because thermogenesis requires that oxygen. Our neural tube and abdominal wall defects have increased surface area for that heat loss and evaporative loss. And even when mom has been sedated, or our infants who have been sedated, they have that decreased activity level potentiating heat loss. Infants with infection, that's caused by an increased metabolic rate and increased use of glucose stores. And our infants who come up maybe from labor and delivery or even postpartum with hypoglycemia who need a little bit more help, these babies have a decreased metabolic response to cold stress and then decreased substrates for energy. So we see these babies every day, but how often do we really think, oh my gosh, is there a temperature accentuating the problems that they're having? So some other let's talk a little bit about 3 methods to heat production. This is something that we all do. We use motor response, we use our tone, and we use activity. And if you think about it, when you have decreased motor tone and activity, you're not going to have a lot of heat production. If you have low tone, it leads to inability to use flexion. So we know with us, when we're cold, we curl up on a couch, and you'll see us in a fetal ball, right? We'll curl up in the corner of a couch. And when we're hot, we usually lay there flat, not curled up, because we want to extend, because we have more surface area to eliminate that heat, okay? So flexion used to stay warm. If you look at our babies, unless we actually position them in flexion, they are going to be in constant extension, which means a larger surface area to lose that heat. So again, they don't have the ability to do this. So even something as simple as how we position babies can help warm them in that flexion to just promote that smaller surface area. And simple things like that. What we can do as adults is we shiver, and that's how we warm ourselves. It's the most significant method of heat production in us as adults. Neonates really can't shiver until a month or so of life, and so they use other methods, and that's chemical thermogenesis. And shivering is a muscular response, and that increases our metabolic rate and increases O2 consumption also. So it's kind of good that they don't, but this is how we warm ourselves up. So before we start talking about how these small babies and term babies do it, I just want us to, again, look at the brain size, because remember, it's the central nervous system, it's the brain that controls our thermoregulation. So if you look at that poor baby who's 25, 26 weeks, they are not there yet, so we really have to support them. Even the infant at 32 weeks, and some of these babies are already getting into open cribs, and these late pretermers, 34, 35 weeks, still have a lot of brain growth to happen. So again, we need to really be there for them. And so I always like, I think there's not one presentation I do that doesn't have brain pictures, because it's that unseen organ, and I think we forget how much is controlled by that. So let's talk a little bit about thermoregulation. It's probably a review that the hypothalamus is the control center for the temperature regulation, and that's located at the base of the brain, and it forms the floor and lateral wall of the third ventricle. It actually links the nervous system to our endocrine system, and it's part of the limbic system, and the limbic system is really, really important, and that to me is like the seventh system, sensory system. The limbic system is who we are. It really regulates the instincts and everything that we do that makes us who we are. It's responsible for the metabolic processes, but it controls our body temperature, hunger, fatigue, sleep, and circadian rhythms. So if you look at all those things, it's really important that we understand thermoregulation. The skin actually is primarily the face and the spinal cord senses thermal stress of babies. And the hypothalamus processes this and initiates these series of reactions to either increase heat production and decrease heat loss. So I want to talk a little bit practically later about when we have bag and masks in our incubators that might be on blowing to the face, because that really is what starts the process. So let's talk a little bit about white fat and brown fat. So white fat for us serves as insulation, and the fetus makes white fat during development for energy and not for warming. And if you can see these little pictures down at the bottom, the left picture shows some brown adipose and then some beige and then white fat. And if you look at the left, the brown adipose tissue or the brown fat, you'll see these smaller dark brown what do you call them? Just little circles, and that's mitochondria. And you'll see that white fat doesn't have very much of that. And mitochondria is what helps the body heat up. So if you look over to the brown fat, and burning produces heat. The mitochondria metabolizes fat, and that's what produces heat. So there's a lot more mitochondria in the brown fat. So if you look at these pictures of these babies, it's really, really important to see where the brown fat is. And the one place I'm going to focus on it the most is I want you to keep, if you remember anything from this, is that there's brown fat in the axilla. So just keep that in mind when we talk about temperature measurement. And you can also see that it's around the adrenals and around the kidneys. So when we have a baby prone, we're also going to think about where we put that skin temp probe. So keep that picture in mind throughout the rest of the presentation. So the next couple of slides will be kind of scientific. You will have the handout so you can look at this in a little bit more detail because I want to get more to the practical stuff. But babies warm through something called non-shivering chemical thermogenesis. And heat, again, as a review, is produced by metabolism of brown fat. So what happens is these thermoreceptors transmit impulses to the hypothalamus through the face, the skin of the face primarily, and it also is over the spinal cord. And it stimulates that sympathetic nervous system, causing norepi to be released in brown fat. And it's found around the scapula, the kidneys, the adrenal glands, the head, the neck, the heart, the great vessels, and axillary regions. Again, remember the axilla. And then what happens is norepi in the brown fat activates lipase, which results in glycolysis and fatty acid oxidation. The glycolysis then increases the metabolic rate and increases heat production. The norepi then gets released at the brown fat site as a result of the cold stress, and then what happens is you have that combustion in the mitochondria of the brown fat, and that's what releases heat. So if we real quickly think, a baby gets cold stress, maybe some cool air is blown in the face, we pop up the giraffe top, or we're taking the baby out to go onto mom, and the baby gets some cooling around their face. It stimulates this process, and all of a sudden you start getting this release of norepi, it activates everything, you have this glycolysis, and then all of a sudden you start getting the combustion of the mitochondria. So what happens is if your mitochondria is responding to cold stress to increase heat, and you have mitochondria and brown fat, in your axilla, you're going to have a higher temperature. But remember, in the back of your mind, keep this in mind, that doesn't necessarily, remember that mitochondria stimulated the production of heat in the brown fat because the baby was cold. So that means that an axillary temperature might mean that the baby is hot, but it also might mean that the baby's cold stress. So we're going to talk about that a little bit later. I'm not going to go over this slide in detail, but I want you to have it and look at it. The point of this slide is the consequences of cold stress. The infant responds to chilling by increasing their metabolic rate. But if you look at all the cascades of what can happen, it increases caloric consumption. These babies already have a failure to gain weight. The last thing that they need is caloric consumption. Look at what it does to the pulmonary system. Look at what it does to the glucose consumption and can contribute more to hypoglycemia. And just look at the cascade, and all the way to the right, it can also interfere with clotting factors. So again, when you look at all the types of babies that we take care of, from the micropreemie to the cooling baby and the cardiac baby or the ECMO baby, any of those babies, so many of them have all of these issues. But how much time are we spending on what's going on with their temperature? And so that's why I think this is so foundational to understand. And it's really, I think, complicated, yet very logical. And it's very nurse-driven because this is what's happening at the bedside. And we see this baby's temperature from second to second, minute to minute. So I think it's really important that we understand this. Here's just another quick picture. If you look at this baby, you have the baby gets cold, so he increases oxygen consumption, and then what is he going to do? He's going to increase his respiratory rate, right? Which could lead to pulmonary vasoconstriction, which moves you over to decrease oxygen uptake by the lungs. So what do? You'll probably start desaturating. You can also have peripheral vasoconstriction, which can decrease your PO2 and pH. You also have decreased oxygen to the tissues. So eventually you're going to have metabolic acidosis just because this baby is cold. So you can see how it can aggravate already present diagnoses like RDS. Real briefly, we will go over the mechanisms of heat transfer. So you can see here on the upper left, you've got your conduction. To the right, you've got your convection, evaporation, and then our radiation, which is the most undetected, and we'll quickly go through these. So evaporative heat loss is the transfer of body heat through conversion of liquid to vapor, and 25% loss happens at delivery alone. What about respirations? A baby actually cools down through respirations, but what if they already have TPN and they're trying to cool down? Because we're not going to only talk about hypothermia, but hyperthermia. It's also dependent on the airspeed and activity around the baby, and it's increased with low humidity also, and I think that's a general practice that we have, and we'll talk about that also. So what are some interventions, simple interventions? You dry your infant after birth, but now we'll have to talk about those polyethylene bags too for the small baby. You also want to pre-warm blankets, hats, solutions, oxygen, and we'll touch on that in a bit. But this is your evaporative heat loss. The next one is convective heat loss, and that is the transfer of heat to the air moving across and around the body. It's dependent on the speed of the air. It's dependent on the amount of the body surface that's exposed. You know, I wish we could keep our little babies in a little egg, a little cocoon here, so that not much is exposed. But unfortunately, we don't have that, but that's why we use incubators. It's also dependent on the temperature gradient between the infant and the air liquid. So, you know, what are they near the vent and cool air is blowing, something like that. And the larger the gradient, actually the greater the heat loss. So that makes sense. And some interventions are warming oxygen. We'll go over some studies on that. Avoiding vents and drafts. And then swaddling and utilizing clothing and products, developmental products, is really, really helpful to decrease convective heat loss. Conductive heat loss is the third, and that's where you have the transfer of heat between two solid objects that are in contact with each other. And that also is proportional to the size of the temperature gradient. So you know we warm our hands before we touch the baby, and that would be conductive heat loss. You can also have heat gain from object warmers than the body. So thermal mattresses. If a baby is on a hot one and we're not careful, the baby can get actually too warm. So some of the interventions that we want to do is you want to pre-warm all surfaces. Scales, x-ray plates, circ boards, warming up the incubator walls, always have that turned on before a baby's admitted, warming the warmer, clothing, stethoscopes, blankets, all things like that, never putting those cold straight from the cupboard and putting those right next to the baby. And then finally, radiation heat loss, and that actually is very highly undetected. It's that transfer of heat between two solid objects not in direct contact with each other. It's independent of the ambient temp. So, I think about our units now, depending on where you live. Here in California, it's cool in the morning and at night, and in the middle of the day, it's very, very hot. So if a baby is next to a window and in the morning it's very cold, the baby is next to the double-walled incubator wall, and then the double-wall incubator wall is next to the window, and the window is cold. So what happens is the cold window wants to get heat, so it's going to pull from the next solid object. So it's going to pull to the double-walled wall. And then the double-walled wall wants to get warm, so it's going to pull from the baby. And so that's radiation heat loss. Now, during the afternoon when it's really hot, that's going to be radiation heat gain. So what I recommend is if a baby is by the windows and you have curtains or you have blinds, utilize those blinds, double blinds, to modify the environment and not like go up and down on your incubator, because then your baby is in an NTE. So interventions that you might do is swaddle your infant, pre-warm your incubator, cover incubators. We know that in most of our units we cover the incubators. The one thing I want you to look at and be careful of is, and I don't know how clear this is, but what can happen is if you have too heavy a blanket, sometimes what your incubator can do, because it's like insulating, you can see that the air temp actually is 32.4. That's what it's set at. But the actual temperature is 33.4 because it's so insulated in there. So always just keep an eye on the difference in what you have it set at and what the actual temperature is inside because of your covering. So just those kinds of practical things to do. One more I want to go back. The other thing that I've noticed, and I doubt if we're the only ones, but as the nursing force gets older, we're also faced with our changing circadian rhythms and set temperatures. That's a nicer way of saying menopause, or as I call it, my own personal fireplace. I find that we change the thermostat for our own comfort. So I think be really careful, put on a jacket, take off a jacket, things like that, or a cover gown, because we want that baby to stay as neutral, in a neutral thermal environment as possible. And that also means not just the incubator, because remember the air temp around it can also modify it through radiation, heat loss, and heat gain. So I think it's really important that we try to keep our units in the consistent temperature range and consistent humidity range. So let's talk a little bit about what hypothermia is and what those symptoms are briefly. So hypothermia is a rectal or axillary temp less than 36.5. Core temperature below range of 36.5 to 37.5, and skin temp can be about 0.5 to 1% lower than that. The underlying things are the ones that I want to focus on. We know that there's cyanosis and acrocyanosis with hypothermia, but one of the things that we see kind of on a consistent basis are these three things that are underlined. If you're getting babies fairly quickly after delivery, that even are the bigger babies, is they won't feed very well. They might have increased residuals. They might have some bradycardia. We often will see if a term baby is coming upstairs, but they unusually have a heart rate of 90 or low 100s. Sure enough, they're not feeding very well, and we put a skin temp probe on them, and sure enough, they're 35.7, 35.9. We warm those babies up, and all of a sudden, they just wake up, and they start eating better, and their heart rate comes up. So those things they're subtle changes, but they're so related to hypothermia and just a low temperature, and that hypoglycemia too. Some of these other ones are there, but I really want to focus on some of those simple things that we see every day, and are we focusing and looking first is the first question. Hey, is this baby's temperature in a good place for that baby? Some hypothermia studies just to kind of quickly go over. Laptook in 2003, they studied over 5,000 babies in a weight range of 401 to 1499 grams, so the high-risk babies, according to Vaughn. And 14.3% had an admission temp less than 35. That's hypothermic. And then 32.6% in the 35 to 35.9 range. And what they found, their results were that admission temperatures inversely were related to mortality, with a 28% increase in death for every 1 degree decrease in temperature. That's significant. Miller in 2006, and this is in my state, CPQCC is California Perinatal Quality Collaborative, and they studied over 8,000 babies, almost 9,000 babies, with a mean admission temperature of 36.3, okay, plus or minus 0.8. And 30.5% had mild hypothermia on admission, and almost 26% had moderate hypothermia, and it was associated with a higher risk of IVH and death. So that's significant, and I think that's why the studies are showing more and more that it's an independent risk factor to morbidity and mortality. So what do we do to treat hypothermia? You definitely want to rewarm slowly. Rapid can cause heat-induced apnea, actually, hypotension, and shock. The first thing you want to do is place a neutral thermal environment. The challenge is that the charts that we all have, the Scopes chart and all that, that we have been driven by, I started in 1982, and that chart is still posted in our unit. But that chart was before double-walled isolettes and before we swaddle, before we have developmental products, before we had these mattresses and things like that. So you have to remember that those are all starting points, so we're going to have to modify and make adjustments, okay? It's not going to be this black and white. So some other little things you want to do is assess your ventilator temperature. one of the first things I do, if I'm walking by a bedside and you see a skin temp that's maybe 36.2 for a very low birth weight baby, and I'll see they're on bubble CPAP, first thing I'll do is look at the heater temp, the vent temp, either the CPAP, the bubble CPAP, or the vent temp. And I make sure it's in that 36.5 to 37 range, okay? Because you have to remember that is heated air going right to your core. So that is actually one of the best ways that you could warm your baby, is just making sure that that is always in that good range. And it's something so simple, and you can see it just by walking by. You want to monitor axillary and skin temperature. Again, if I can leave you with one thing that you remember, monitoring with 2 types of temperatures, you're going to get your best range of temperature and your best assessment of really what's going on with that baby. And then you want to utilize other sources and minimize changing incubator temp. We often see a baby is cold, so you go up on the incubator temp, and then the next shift is feeling the effects of that. And then what happens is, from shift to shift, you have all these swings. So the baby is cold, put a warm blanket on the baby. Maybe we had just been in it for cares, but instead of modifying the environment and those swings that are going to happen, maybe utilize other things. Maybe remove a blanket, remove a hat, and things like that. So these are all things to just ask yourself when you see things, what might be causing it. And then you want to reduce the heat loss mechanism. If they're in a warmer, is there evaporative loss happening? If they're next to a window, is there radiation, heat gain, or heat loss happening? Think in that process. Hyperthermia is a temperature greater than 37.5. It can be iatrogenic or symptomatic of a disease process, as we know. Increased axillary temperature, though, can also be a symptom of cold stress. Remember that. That's where you have your brown fat. And when a baby's cold, those mitochondria get really busy, and they combust, and they produce heat in the axilla. So you got to be careful about that one. And then it usually occurs by means of an external source, generally, for us. It's rare that a very low birth weight baby has a temperature. Some other causes are maternal fever. It could be your equipment, your environmental temp. It could be we've over-swaddled. It can be an infection. It could be CNS abnormality, misuse of equipment, or broken equipment. Infants with neonatal abstinence syndrome because of their irritability and their activity. So highly recommend protecting these babies and keeping them as calm as possible. And then use of prostaglandin therapy. We know that's one of the side effects of initiation of prostaglandin. Some effects of hyperthermia, obviously tachycardia. The one thing always remember, too, is tachypnea, and they'll do that in an attempt to release excess heat. So is their respiratory rate because of TTN really now, or is it because they might be warm and they're trying to cool themselves down? If they are very tiny and you have evaporative loss through you're going to have a higher insensible water loss, so you can have hypotension and dehydration from that. So if you're already hypotensive, you want to make sure you've got good high humidity in your incubator, and that can decrease significantly your losses, insensible water loss. You can have apnea, and also increased oxygen requirements. I don't know how clearly you can see this, but this temperature says this is oxygen consumption, and the first bar is a temperature of 35.5, 36.5, and 37.5. And the key is the lowest is around your normal temperature, but warmer isn't always better. Just remember, if your baby is also warmer, they're going to have higher oxygen needs, and they're also going to have a higher metabolic rate. So if a baby is too warm and they're not gaining weight, be careful about that also, because that increased metabolic rate can make you burn more calories and then not gain weight as well. So treatment of hyperthermia, obviously treat the cause if you know it. You want to remove the heat source if that's what it is, or remove the barrier to the heat loss. You want to look at your equipment. You want to cool slowly. You don't want to be too quick about it. And yes, you can, if the baby is flexed and you've got a lot of equipment around the baby, you can extend the baby a little bit more, and they'll lose a little bit more heat because of the increasing the body surface area. So how do you manage the physical environment? no single environment really is appropriate for all infants. And so again, it's no absolutes, and the medical condition and other situations can require a compromise. So we really need to ask ourselves questions, and it's asking ourselves the right questions. So standardized guidelines is definitely the way to go, but again, each situation is going to be different. So when it comes to thermoregulation, it is really important to ask the right questions. So let's look at the radiant warmer. If we need a baby to be in a radiant warmer, the advantages are the infants who need observation. You can see what's going on, and it's easily accessible. That's great for us, right? The disadvantage is you have increased convective loss and you have increased evaporative loss, which means increase in the insensible water loss. And one of the biggest things for your small babies is a decreased neuroprotective environment. So even though we might have a baby, say, in a giraffe warmer, but if we pop the top to do cares, we're canceling out the fact that they are in a giraffe. So, you want to think about things like that. I also found this one article that talked about this is the surface of a warmer, so the mattress, and they showed the heat temperature of the radiant warmer, what warms the area. So if before the baby was in, this is the temperature of where the baby essentially would be laying, and then here's the cool area. So I think what I took from this is be careful that the baby isn't down this way too much, that really center that baby in the middle, because that is where the focus of the heat source is directing its heat. Okay. So warmer management. We know that you want to maintain your warmer in the servo or skin mode. Sometimes it's in manual mode when a procedure is being done and the baby is obviously covered with towels. But when the baby is in the care mode, you want to be in the servo skin mode. Really, really important, is that the probe attached to the skin surface is with a reflective device and it's exposed to the heat source. It should not be on the side of the baby because that reflective shield needs to be in alignment with the heat source. And that is, if you looked at your books, your manuals, your equipment manuals for those warmers, they will all say that. And then what you want to do is set your temperature to your desired skin temp. So if I want my term baby to be 36.3 to 36.5, I will set my skin temp at 36.3. And what the assumption is that my baby skin temp will maintain around that 36.3 to 36.4 range, okay? You want to avoid use of thermal blankets underneath those babies too, because it could overheat that baby. And what you're doing is, if you're on a thermal mattress, you're also raising the baby higher towards that heat source, okay? And then when you wean, if you're going to wean from a warmer to a crib, generally try to wean, don't go from like a 36.5 to off. Try to wean from a 36.5, 36.4, 36.3, like that, before you actually put the baby in a crib. One of the things that we do in our unit, which I love that the staff does, and we have a really good success with babies not having to go back into incubators or going back under warmers, is we put a temp probe into our monitor. And even when a baby is weaning from a warmer to a crib or from an incubator to a crib, we keep a skin temp probe on for 24 to 48 hours so that we can see early thermal stress and intervene really quickly. So you can wean from a warmer and then also use a skin temp probe that you can get for your monitors. If you have any questions, you can contact me about that later. What about an incubator? So the advantages of an incubator is that infants are requiring controlled thermal environment. You can provide that. It minimizes evaporative and convective heat loss. You still have radiation heat loss, but you decrease these other two. And you can use it both in air and servo mode or skin mode, which is nice. So let's talk about the servo skin mode. The radiant warmer and incubator both can be practiced like this. And what it does is it regulates your air temp to your preset skin temp. So you tell the computer, I want my skin temp to be 36.7. And whatever that computer has to do to keep that baby skin temp, that it will do. It will regulate the air temperature. The problem is that as infant temperature fluctuates above or below the set, temperature servo control changes. So 1 hour you can be, again, your baby stays at 36.7 because I told the computer of the bed to be 36.7, but 1 hour my air temp is reading 32. The next hour it's reading 35. The next hour it reads 30. My question, when I talked about asking questions, is that really a neutral thermal environment? Is changing from 32 to 35 to 30 a neutral environment? It kept my baby's skin temp okay, but is it masking something, okay? So the one thing is about skin and servo mode that I love is that it can keep your baby in that range. But the one thing that takes a lot of work is evaluating your ambient temperature regularly. You have to make sure you are aware of whether there is swings. Because if you consistently see a 36.7, you don't want to mask early signs of sepsis, intracranial hemorrhage, and NEC. And one of the first subtle signs of NEC is temperature instability. And you will not see that, or the skin mode can mask that. So you'd want to be really, really careful of that. So monitoring body temperature, what are the things we want to look at? Well, first of all, rectal temperature is closely approximates core temp. Core temp is really what's internal and as closest to the blood temperature, okay? The one thing that most of the literature talks about now is not to actually do rectal temps. The measure is invasive, it's difficult to maintain ongoing, and you do have a possible risk of perforation because I believe it's 3 centimeters in. It takes a turn, the rectum takes a turn, and you could perforate. So you want to be really careful about that. Axillary and abdominal skin temps are the most used. Axillary, they're both accessible, convenient, and safe. They're not invasive, but it's not an ideal estimate of core temp. But you can see changes quickly, so you could minimize the critical temperature of a rectal temp. Axillary and abdominal temperatures are highly dependent on skin temperature, and they are influenced by the environment. So you just want to be careful or be aware of that. So what are the temperatures? So a rectal temp is considered generally a core temperature. It is a late indicator of cold stress. So if that is cold, we've missed the boat. So normal range, according to the American Academy of Pediatrics, World Health Organization, and ILCOR, which is the International Liaison Committee on Resuscitation, they say that normal range is 36.5 to 37.5, okay? And again, the rectal temperature will remain normal until the compensatory mechanism for heat production begins to fall. Axillary temp, again, is easy to use. It's actually close to rectal temp if their temp is normal, and it won't be if the baby is cold stressed. And normal range from the AAP is 36.4 to 37.4. Skin temperature range is a very early indicator, and that is actually one of my most favorite things to measure with, along with my axillary, because I can walk around the unit and I can see it. I can just walk around and just go, oh, 36, my baby's cold. Oh, 37.5, oh, my baby's warm. What's going on? And it just triggers this question mark in our heads. So skin temperature, again, early indicator. It's easy to assess whether an infant is in neutral thermal because you can see the numbers right there. It detects early thermal stress. And your skin temp is the first to fall as a result of peripheral vasoconstriction. So you can know immediately something's going on with your baby. Normal range for a preterm baby is 36.2 to 37.2. And the sweet spot, I call it, is that many studies show that it's that 36.8 to 36.9 range. And so what we try to do is find the sweet spot for each baby. This is your average, but maybe you have a little boy and you notice that his heart rate, he sleeps better, he gains weight, and axillary is in this great range, and his sweet spot is 36.5. So it's always kind of fun, kind of like being an investigator, finding each baby's sweet spot and then putting a little sign on the incubator and passing that on in report. Just say, hey, this baby's heart rate is the best at this. So it's just kind of it's pretty sick, I know. I think it's fun. So skin temperature in a warmer, this is really, remember we talked about a reflective shield. Your reflective shield needs to be in alignment with the heat source. The probe, as you can see in this left picture, the probe is exposed, the reflective device is exposed to the heat source. If the probe is covered, you're not going to get an accurate reading, and which means the heater output is not going to be treating the baby the way it needs and putting out the heat that it needs. So always make sure that the reflective device is in contact with your heat source. So you wouldn't want it all the way over here on the side because the heat source could not see it. So you always want the heat source in its vision. This I found very interesting. If you are using skin temp in an incubator, please also remember that your probe can be covered. Okay, it's not like in a warmer where that heating source needs to see the reflective device. That is not to say you want to insulate it, okay? So avoid laying on it. If a baby lays on the probe, it could raise the temperature by about 0.5 degrees. So I think one of the best things really is like on the flank, because whether you're prone or supine, you're not insulating it. Now, we'll talk a little bit about developmental products in a second. So any kind of developmental product or a blanket or anything like that could insulate it a little bit, but we're talking laying on it type of insulation. But you definitely want a probe cover. And this was an example of tape covering a skin temp probe versus a shield. And this is in relationship to the skin temperature and then what the air temperature did in the incubator. So you can see when a skin temp probe was covered with tape, it showed a lower temperature. And look at what the air temperature in the incubator did. So this was on skin mode. It made it higher, okay? But look at, you put the same shield on the baby with an actual cover, a good cover, not tape, and look at what it did. You were able to get a real picture of what that baby's skin temp was, which meant the baby didn't need as high an incubator. So the moral to this story is avoid tape, and then your reflective device really needs a padding. Make sure you have that hydrogel and that there's a pad after that. Sometimes you'll see a reflective device that has this very thin layer of hydrogel, and that will melt, and then basically all you have is this piece of cellophane, this shiny cellophane covering, which then becomes like a thin piece of tape. So be careful of that. Delivery room practices, real quickly, the World Health Organization in ILCOR in 2010 said the room temperature in delivery rooms should be greater than 25 and should actually be greater than 26. Admission temperatures were increased by 0.5 and decreased hypothermia from 66.8% to 34%, which is very powerful. Delivery rooms need individual adjustment thermostats and humidity controls based on their studies in 2010 and their recommendations. There was another study, a polyethylene cap randomized control trial. The cohorts were polyethylene cap with only body dried, polyethylene bag with the body wet up to the neck and the head dried uncovered, and a control group with infant dried placed in a pre-warmed towel with head left uncovered. And what they found was that the babies in the polyethylene cap group alone had the least amount of hypothermia. And then the polyethylene bag group had a little bit more loss, and then the control a little bit more loss. So the moral of the story was polyethylene cap was superior in this study, but a combination might be best. Other delivery room practices, warming mattresses, some studies on that. Infants less than 28 weeks in polyethylene bags had a mean rectal of 36.5. 44% of less than 29 weekers in polyethylene bags had mean temperature less than 36.4, and the mortality fell from 252 per thousand in the control to 229 per thousand in the bag, and then 175 per thousand in the bag and the mattress group. Again, combining interventions is key. But this one study did say you want to be careful of hyperthermia also. Another question that is going around in a lot of listservs is, what are people experiencing with delayed cord clamping? The baby is generally out for 45 to a minute, 45 seconds to a minute. Some are having warming tables, but a lot of centers are developing guidelines with warmed sterile towels, and at least that being put over the baby. We did notice a dip when we started doing delayed cord clamping. So again, the moral of the story is start looking at these things, ask yourself questions, and put interdisciplinary teams together. Let's see. This was one of the studies. So this is in the delivery room. This was a traditional just warming and drying, and you can see from 32 to 37 degrees. This was using a bag only, and this was a bag and mattress. So that, it shows you temperatures are higher, but they kind of went really high. So that's why you want to be really careful also. So mode of temperature, again, both are effective. Skin needs more attention. If you are in air mode, early temperature changes are noted. Infant's temperature could fluctuate if in and out of the incubator, yes, but it's simple to use. If you use skin mode in an incubator, it automatically regulates air temperature to your preset skin temp. The air temperature changes, creating fluctuations, and is that really a neutral thermal environment? And you can miss early signs or changes to that baby. Real briefly, as far as humidity, actually it was first mentioned as far as long ago as 1933. I thought that was pretty cool. The main goal is to decrease insensible water loss. The studies show that it decreases your fluid intake, which is great for closing your ductus and not complicating your respiratory disease. You definitely have decreased urine output also. Less weight loss and decreased hypernatremia during the first week of life. The unfortunate thing is there's really actually no standards that say for how much and how long. A lot of the studies or the general practices that are talking about what's out there is the range is from 45 to 100% relative humidity, with an average of 60 to 80% in the ELBW, and anywhere from first 10 days of life to 32 weeks. And the goal basically here is to create a unit standard of practice. Any baby less than 32 weeks in our unit gets started in 80% humidity, and they stay in there for the first 2 weeks, and then every week we drop by 10%. But we do keep up until 32 weeks in humidity. Some warming practices. I think almost most units have formula or breast milk warmers, which is great. A really important thing that we have to remember is humidifying air and oxygen and not doing it straight off the wall. There was a cohort study humidifying gas supporting infants' respiratory status in infants less than 32 weeks, and they found a reduction in postnatal fall in temperature in the cohort with the control admission temperature of 35.9 versus 36.4. So it's really important to humidify all of your gases. And then using clothing, developmental supports, and incubator covers. And one of the biggest things is if a baby is cold, baby goes on mom's chest. You can't warm up a baby better than mom. And then some things to consider is how do we approach cares? The first thing is minimal entry, if at all possible. When we are using the incubators, do we use the heat shield? We teach our parents to press the heat shield if they know that they're going to go in to do a hand hug on their baby or to do a diaper change. Also, do we, when we're going to care for the baby and there's a blanket over the incubator, do we pull it off really quickly? That, remember, is going to increase your radiation heat loss. Do we open the porthole doors and then pop the top and lose all that humidity? What are those standard practices we do that we can actually kind of ask ourselves, do I really need to do this? And as far as when you get actually to the infant, do you unwrap the infant completely to change a diaper and to listen? Because when we do that, we have convective and evaporative loss. Can we do a portion at a time? Do people routinely suction? If you are routinely suctioning, you're disconnecting humidified heat source. So again, it's asking ourselves, if I'm going to do this, first of all, do I need to? And then what are the consequences of my intervention and my action? Real quickly, looking at temperature regulation and developmental supports, again, remember, we have all those charts, and that was before we had the wonderful things like blankets and developmental and mattresses and hats and all those kinds of things. And so really if you look at developmental supports, they're very much in blankets. They're very much like being in a sleeping bag, and we know we get warmer in a sleeping bag. So if we have a baby in a blanket or if a baby's in a developmental support, yes, they are going to get warmer. So what we do is not get rid of that, but modify our environment, modify the way we monitor skin temperature. Are we going to change to air mode? You know, do we make sure the room temperature is good? So it's not utilizing these supports because it improves neuroprotection and so many other factors and improves sleep. So it's just thinking differently. Lastly, weaning from an incubator, things to consider. A lot of the literature talks about infants generally that are greater than 1,500 grams, no absolutes. Gaining weight, meeting other milestones can generally tolerate weaning from an incubator. The one thing that is very interesting is I think we often get challenged to wean quickly because babies or insurance companies they want babies out of the hospital. But if you look at room temperatures, our incubators should really be down to 25 or 26 before a baby comes out of an incubator, because 25 degrees is a room temperature of 77, and 26 degrees is a room temperature of 79. And I really don't know too many NICUs that have that as a room temperature. So trying to get down as low as 25 or 26, and this is what our goal is. And our babies, I would say 99% of the time, never, ever, ever have to go back into an incubator. Our staff does a great job. You want to see consistent weight gain. You want to see if mom is skin to skinning or the baby's out of the incubator most of the day and doing fine, maybe you can be a little bit more fast about it. And then parent education, really talking to parents about how we are dressed and then adding one more layer for the baby. And then, like I shared earlier, maintaining skin temp monitoring in the crib for 24 hours after the baby comes out. Again, skin temperature is going to be your first indication. So I want to end with a scenario that I often get calls about or I see all different places. So the scenario here is a 30-week infant that is in an incubator in air mode, and you don't have there's no skin temp probe on, and you go to do your cares and you get an axillary temp of 99 degrees. So my question is, what would you do? And generally, I think based on this, what we would think is axillary temp is 99. That baby looks a little warm. I'm going to decrease my incubator temp. But then what I do is I put a skin temp probe on and I find out that the skin temp is 35.7. So now when I look at that, I would just go, oh my goodness, I would actually make the opposite move. So what that tells me is that my temperature is actually burning brown fat, and so I would make the opposite decision. So do you see how skin temperature and axillary temperature gives you the better picture? Okay? And I think I'm out of time, so actually we won't go through the second scenario, but we will move to any questions. Oh, real quickly, one more slide, I'm sorry. So where do we go from here? We really want to develop interdisciplinary thermoregulation guidelines. Again, guidelines, not necessarily absolutes. Our charts are dated. This is a nursing practice and nursing driven. I believe should be nursing driven, but we need an interdisciplinary team. We have to be aware we're going to make modifications for developmental products, blankets, kangaroo care, and we want to, in these guidelines, avoid using absolutes. We shouldn't be saying things when we're 28 weeks, we go to air mode. When we're 1,500 grams, we come out. We only use skin mode. We only use air mode. Those are all things that we want to avoid, okay? But I think having guidelines is going to be really important for your units. Okay. So I think that's all I have to open it up for questions.
Liz, thank you so much, and I can see we've got some questions coming in already. That was really a great presentation. Again, if you have questions, please type them in the chat box, and I'm going to invite Kathy Randall to come on and help to moderate the questions.
Hi, Liz. Thank you so much for that. So one of the questions is asking, is it acceptable to cover the skin probe with a clear dressing to aid in its attachment to the skin some nurses, some of my nurses practice this way and feel that the probe works better. So what do you think about adding some layers under, I'm guessing, a reflective cover is what I'm thinking they're asking.
If the reflective cover is, if your reflective cover has a hydrogel and a pad, that should be enough. Because then I'm not quite sure, you're saying adding more tape on it to keep it on? Or
yeah, so maybe Teresa, if you want to, maybe Teresa can clarify, but it's just saying, is it acceptable to cover the skin probe with a clear dressing to aid in skin adherence? Is the exact wording.
No, I think, okay, I think your skin temp cover, your heart or your teddy bear, whatever that is, you want it wide enough to cover the temp probe. You want a hydrogel and then a pad on top of that, and that is a sufficient covering to get an accurate skin temp reading.
Yeah, she's actually clarifying. She's saying on top of the cover. So I'm saying so she's saying then putting a Tegaderm on top and covering the reflective cover.
No, that's not necessary. I think
okay.
All that does is it probably could add more and more insulation, and then what kind of a reading are you getting?
Yep. There's a question on some of the newer beds that are recommending that the temp probes be placed axillary versus flank. Do you have an opinion about that recommendation, or have you seen that recommendation?
I have seen that recommendation, and I was wondering if that question was going to come out. I'm going to, okay, so if we look at what we talked about and where brown fat is, wow, that's a tough one. So, okay, if we're using an axillary temp probe and you're in skin mode, I would avoid that, okay, because I would only suggest using an axillary if you also have a skin temp probe on, but you are in air mode. Because again, if that baby is cold stressed, your axillary, that skin temp probe in your axilla, could be reacting to cold stress. So unless you have a skin temp probe, you're not going to know which it is. Is the baby hot? If the axillary skin temp probe is high and you also had an abdominal one and it was high, then the baby's hot. So personally, I would not practice like that because I know there's brown fat in the axilla. And I definitely wouldn't do it if I'm in skin mode.
So as the CNS in your unit, would you write the protocol for that to be both? I mean, like, so if they're in this situation where now they have this education that you shared with them, now they feel nervous, how can would they just work with their educator and their CNS to kind of talk about that and to adjust?
I would. What I would do is, and again, it's asking those right questions. Here's what I would do. I would put the skin temp probe like they are being directed to in the axilla, but I would somehow get an abdominal skin temp probe. I would try it in air mode. Does that make sense?
Mm-hmm, mm-hmm. So saying that it's maybe not 100% wrong, like you're saying, it's a guideline, but if we use our critical thinking, there are times when that makes more sense to be using the axilla, like you said, like when the baby's transitioning and you want to just have a kind of a monitoring experience, similar to what you'll do when you're taking temperatures. Okay, that makes sense.
Right. Yeah, because it's again, if you're in skin mode and the only skin temp probe is in your axilla and the baby happens to be cold, that skin temp probe will say the baby is hot if they're burning brown fat, and that will turn your incubator down.
Mm-hmm.
Okay, so that's where it's definitely asking yourself, well, we want to use the axilla, okay, would that make more sense in air mode or skin mode? Okay, and if you want to do it in one of those modes, put a skin temp probe on the abdomen and then kind of do your own little research.
Yeah. There's a question from Meritor in Madison. Hello, Madison, Wisconsin. What are your thoughts on dressing babies once they have weaned to air control in the incubator? Would you recommend dressing them in a t-shirt or a full sleeper? So air control in an incubator, dressed or not dressed?
Okay, that's a great question. So our unit actually, after the first week of the low birth weight, we go to air we go to air temperature like after 3 days, 5 days of life. We are in air the rest of the hospitalization. We put clothes on the baby, and here's what I would recommend. And it's interesting. It's not from a thermoreg standpoint. It's from a neuroprotective standpoint. Putting clothes on a small baby on and off is very disruptive to the skin. It's very disruptive to sleeping and body movements and things like that. So we actually put clothes on a baby. This is what I would recommend when you are getting ready to come out of your incubator. So when you're about at 27, 26 degrees, we generally start putting clothes on a baby. Yes, a T-shirt. Sometimes we'll ask mom to bring in a onesie, and start modeling how that baby would look in a crib. So we start talking about, Mom, you and I would not be in our underwear here right now. We have pants on. So a baby being in a T-shirt in a crib just with the blanket wouldn't be enough. So we slowly move in the direction of around 20, when the incubator is about 27 degrees, to start putting clothes on. But again, then the baby is more, from a neurodevelopmental standpoint, able to handle touch a little bit more.
So you use it as part of that transition to a non-regulated, a non-regulated environment. Okay, another question from Pittsburgh. How do you adjust for infants' higher temps when they have NeoBlue, Billy lights, Billy blankets, overhead phototherapy, and they're in heated beds? So we're talking term or near term babies who are, I'm guessing, heated beds, meaning like a radiant warmer.
Okay. Well, from what I understand, the LED lights from all the phototherapy don't really put off as much heat. I do notice when they're on the blankets, they do warm up. So we never have the baby with the skin temp probe laying on the blanket. So we wouldn't put the skin temp probe on their back with the baby laying on it, because it does increase it. It's hard to say, because it depends on how you practice. If you always use a skin temp, you're just going to make modifications because you'll know that baby's warm or cold. In a warmer, as long as your skin temp probe is in vision of the reflective device, it shouldn't really matter. The only thing I'm thinking is if you have old phototherapy lights that do put out heat. So okay. that one's a hard to answer, because I don't know what kind of phototherapy lights you have.
Yeah, so she specifically was saying the NeoBlue.
Yeah, I think from what I understand, they're not supposed to put out heat. LED lights should not put out heat.
Yeah, and she's clarifying that she was meaning inside Draeger, not a radiant warmer in the Draeger bed.
Yeah, I look at my axillary temp and my skin temp, and I make modifications. We might have to turn down during phototherapy. We turn down the incubator temp. And then when we know the lights are coming off, we'll probably put some clothes on. And that's why we always monitor skin and axillary. Every baby has a skin temp monitor on, probe on, from birth to 2 days after they go into an open crib, because I can tell instantly what that baby's doing.
So you keep a skin temp probe on after you transition them?
To a crib, yes, for 48 hours.
And then how do you monitor that skin temp? Do you have a specific?
There's skin temp. We have Philips monitors, and I think most monitors actually do have capabilities of skin temp probe. You can purchase the skin temp probes, and they are very long cords. And we just plug it into our Philips monitor and our module. So monitors.
So into the actual monitor.
Yes, into the actual monitor for 48 hours. And it's great. Babies do not go back into incubators, because you can detect quick thermal stress from the skin temp probe the skin temperature dropping, and you can put another layer on and all that.
That's great. That's great. I think that's the last of the text questions. If anybody has any other questions or burning questions, Liz, I'm sure she's willing to answer questions by email. She's put her email here if you want a list of her references. We put you'll get a copy of the handout. She's graciously provided that as well. So I'll turn it back over to Kathy Bush for any final comments. But thanks, Liz. That was great.
Thank you.
Yeah, thank you, Liz. That was really awesome. DandleLION is just so proud to put on webinars like this with great faculty like Liz. So we really appreciate your depth of knowledge and your really practical advice on the topic. DandleLION does actually have a thermal hat, we're happy to say. It's a layer of polyethylene, but it's sandwiched between two really soft layers of knit. Comes in a preemie size and a newborn size, so there'll be a place in the evaluation. If you want to check a box, we'd be happy to send you a free sample of both sizes. Several hospitals have done trials with the hats, and Liz had mentioned that too. And a thermal hat really does make a big difference for a lot of these kids, especially in the OR during transport, as well as just, out of the incubator. So now on to the business part. If you want to receive your free CE, you will need to fill out the webinar evaluation. In the chat area, you can click on the evaluation link that Kathy just put up, or once we're finished, you'll be immediately redirected to the evaluation form as long as your firewall will allow it. At the end of the evaluation form, you'll receive a link to the CE certificate. If you don't have time to fill out the evaluation right now, or your hospital has blocked access, you will receive an email, hopefully within the next few hours, or at least by the end of the day, with a link to the evaluation, as well as a link to the recording, and the PDF of the slides will also be linked to that email. Now, one thing, if you're viewing as a group, you must each log into the evaluation form to get the CE. So we'll hope that you will visit DandleLION Medical website for future webinars, and also links to the recordings of our previous, I think we're up to 34 webinars now, many of which are still active and available for continuing education credits. So everyone have a great weekend. Thank you all for participating, and many thanks to Liz Drake for another great DandleLION webinar. Thank you, everybody.